And let me open the discussion and invite Dr. Praveen Chandra and Dr. Tulio to actually lead the discussions. And my first question to Dr. Praveen would be, do you find any case which is in your now, which cannot be done, TAVI cannot be done because of access issues? Because I see you go from any site, from any arterial access or venous access. Do you still find any case where you turn down the patients because of access?
So a very nice presentation by Dr. Sanjay. I think he does great jobs over there, and we hear nice stories from his center. So congratulations, Sanjay. Listen, so the thing is that as far as the access is concerned, I think, we are in a situation where carotid access is really working out very well, and the complications are absolutely minimal because of two reasons. One, that our surgeons are very well versed with the carotid access. I mean, they just give it in 2 minutes. And for subclavian also, they do it, the vascular surgeons are very well versed. So there is no problem. For the cable access, it is an initial 1 or 2 cases of learning. Otherwise, it is also a very simple and nice access. In fact, I can tell you, this feels to me better than even the transfemoral access, because there is no chance of complication of the vascular site.
Interesting.
So, given, maybe in some time, we will all switch over from the transfemoral arterial access to this transcaval access. It is so good. And of course, no, there are no cases where we were not able to do because of any access issues. So it is really working out well. And there's at least, there are 6th access, which is another one where we have nothing. Then we can have a small cut over here and go from the right, open access, which is the direct aortic access, which is also a good access site, and it works out quite well. But here we need the cardiac surgeon to just open the chest a little bit, and then they, show us a site, and then we can puncture, go straight inside. So these are the ways to handle access site issues.
Thank you, Dr. Chandra, for excellently taking care of difficult patients too. But I think all the trial data, what they showed is what applies to transfemoral access, especially when you're dealing with low risk and younger patients. I think still where surgery can be done, I think you should be doing it. And where patients are not suitable for surgery, then all your options of exploring to save lives are applicable. I think we have moved from era where we were taking care of only surgically unfit patients. Now we are going to the era where if we find patient is not suitable for TAVR, those could be going for SAVR in future. Only thing is, you need to keep the age in mind, because we don't have data of long term because of degeneration. But I feel when the surgeons are putting a bioprosthetic valve, it is working. Even when we put it also, it should work longer. So I think as of now, only for those complex cases of difficult access where transfemoral access is not possible, then probably we should discuss with surgeon and try to, in low risk and younger patients I'm talking, try to send for surgery. And if you're not suitable, surgeon refused, obviously what you're doing is great to save patients' lives. What are your comments on this?
Absolutely.
Dr. Khanna, if you allow me, I'm Ivo Petrov.
Yeah, sure. Dr. Petrov, please go ahead.
Yeah, Dr. Praveen, it's impressive what you have shown about the alternative accesses. All we know that into the trials, in fact, the benefit of TAVI compared to surgical intervention was shown by femoral access.
I couldn't understand the question, Dr. Khanna.
You're muted.
The same what I told. Only for femoral access, it was proven, he says.
Okay, yeah.
Great.
So let me now tell you that is why.
What I wanted to say that we have additional options to provide femoral access, like shockwave technology now. Even in very calcific cases, we have done 2 cases like this on a very calcific iliofemoral segment with a shockwave and gentle balloon dilation. We succeeded to put a large sheet, and through the large sheet to make the procedure done. But of course, always we have to be prepared for alternative accesses. And you have shown, I was definitely impressed by the caval transcaval case, it's definitely very, very interesting and very good, very well done. Thank you.
Thank you.
So, Dr. Chandra, I mean, another way, I mean, when we do our aortic work, the endovascular repairs and large bore devices, many a times when we have these calcified arteries, now we have the EVL, but the EVL, there is a problem. It's only the biggest size of balloon we have is only 7 millimeter as of now. The other thing which really works is endolining these, iliacs with a covered stent, and then we take a high pressure balloon and high diameter balloon and blow, rupture the vessels under a controlled environment, and then it gives us a good wide lumen vessel to actually go ahead and finish our procedure. The question which I had in mind was, if you think that the trans IVC approach is very good, will you always go ahead and preemptively put a covered stent in the aorta, or you will still just put an implanter device to seal that as a routine?
Yeah, in fact, either of them is good enough, but I will suggest, yes, the first choice should be an implanter device. ADO 8 millimeter works very well, but one should be prepared with a self-expanding covered stent. It should be standby, and if required, we can just put it immediately, and it works out quite well. So either of the things can be done, but most of the series have used the ADO occluder, which is quite good to do. And basically it completely blocks the path from the aorta to the IVC.
Praveen, I would have one concern, that would be that if your aorta is larger and you cannot put what you call as a low profile self-expanding stent, you have to go with a Valiant device, then you're almost reaching the same size as what you need for TAVR. And in that case, I think what we discussed, the use of IVL or pre-dilatation is important. But if you don't have any femoral access at all, then you have to get an access from somewhere else to get the covered stent down. And these are all difficult things, but I'm sure that with our experience and your experience, we would be able to manage most of them without a problem. The only problem is that if your device pops out, as it did, and you don't have a covered stent, then you are in some kind of a trouble for which you'll have to, find a way to sort it out, which is difficult.
Yeah,
it is
absolutely
likely to happen. And as we discussed, that it'll be better to try to use a device rather than a covered stent as a first choice. If that doesn't work, you have a backup. And these always work. Suppose you have still leaking, then you can put a backup covered stent also, because it's possible to still leak. So these are all things which we learn over a period of time. It's not necessarily that all of us have an answer to all these things in the beginning. Over a period of time, we become smarter, and we have.
Dr. Chandra, actually, you're having done so many carotid access. Nowadays, this Manta device is supposed to be doing the job without any constriction or without any block having done inside. Would you think in future would be able to close percutaneously and have access of carotid also like this with the newer devices?
I didn't get your question.
Now we are exposing cutting with the surgeon, carotid and all that we are doing. In future, the Manta device, the advantage what they show is there is no constriction of the artery, there is no problem of inside the plate coming in. So would you feel in future if these newer devices come, can carotid also be done through percutaneous ways of closure device?
Yeah, I mean, we can even do it with the ProGlide.
Human body is great, it tolerates it looks. I think we can try that also in future.
Yeah, the Manta device is also somewhat like the AngioSeal only. We can use that, and it is it's an extra vascular closure. So it's okay, we can even do that. But it's so easy to do this. It's cheaper, it's a cheaper way to handle the arteries rather than using an expensive Manta, etc. Because the surgeons just open it. It takes 2 minutes, and to close it, it again takes 2 minutes.
Yeah.
So it is fastest way to handle and let me tell you, for carotid also, many times we felt that it is better to go with carotid access, because then the procedure time is very short. I mean, you can finish the case in 45 minutes. Yeah.
Okay, thank you.
So thank you all very much. It was a very wonderful session and a lot of learning in TAVI, and that's why we kept this session as hot topics in TAVI rather than the routine stuff. with the stalwarts doing TAVI actually speaking on the procedure and the complications. So
Thank
thank
you.
you all very much. We are moving on to the next session.